So we have now looked at how we select our patients. What do we do before the HIFU treatment to help reduce the tumor volume, to reduce the signal intensity? We look at how to conduct the HIFU treatment. We look at treatment outcome assessment, and let's take a look at the pregnancy outcome. So HIFU is a non-invasive uterus preserving technique. That's why understanding the ovarian reserve after the HIFU treatment is important. So we assess the ovarian reserve and function by measuring the anti-Müllerian hormone, the AMH level. So AMH is a glycoprotein hormone produced by the granulosa cells of small growing follicles in the ovary. So in this study, 74 patients were included. 69 patients have symptomatic uterine fibroids and 5 adenomyosis. The median AMH levels assessed before and 3 months post-HIFU is presented in the graph below. So if in the top left-hand corner, you have the AMH level for all the patients before the treatment at 1.2 microgram per liter, and the range between 0.1 to 7.75 microgram per liter. You can see before the HIFU treatment and after the HIFU treatment, there was no significant difference between these two groups. And then if you now do sub-analysis, looking at the different range of AMH level before the HIFU treatment, now we look at in the top right-hand corner, between 0.1 to 0.98 microgram per liter. Before HIFU treatment, the AMH level is around 0.58 microgram per liter. After HIFU treatment, it's around 0.52 microgram per liter. Again, no significant difference between these two groups. In the lower left-hand corner, you look at the range, the AMH range between before HIFU treatment between 1 to 2.5 microgram per liter. You can see that before and HIFU treatment, 1.62 and 1.66 microgram per liter, there was no significant difference between those two. Now the last part is let's look at the lower right-hand corner, the AMH level more than 2.5 microgram per liter. And similar to previous results, there's no significant difference between the AMH level before HIFU treatment and after HIFU treatment. So the change of AMH with AMH is also compared to the different fibroid locations. What you're looking here is a graph where the y-axis is the AMH value change, and on the x-axis we're looking at 4 different locations of the fibroids in the anterior wall, posterior wall, fundus, and lateral part of it. You can see over here the location of the fibroid does not affect, where we ablate does not affect the AMH value change. And then in the table below, we look into the correlation between the AMH level and the total energies, the total acoustic energy at the focus and the MPV ratio. And again, you can see over here, there's no significant difference between them. So the conclusion for this study is HIFU does not compromise the ovarian reserve of the patients. Next, let's take a look at what happened to the endometrial enhancement. The objective of this study is to evaluate integrity of the endometrial enhancement after HIFU ablation of submucosal fibroid based on MRI findings and to identify the risk of endometrial impairment. So this study included 117 submucosal fibroids. The degree of protrusion into endometrium is divided into 4 different grades. Grade 0, 47, grade 1, 51 fibroids, grade 2, 11 fibroids, and then grade 3 is 8 fibroids. So how do you assess the endometrial impairment using MRI? We're looking at grade 0 to grade 3. If you look at grade 1, for example, you're going to look at pinpoint full thickness in discontinuity of involved endometrium. So grade 2 is between grade 1 and 3, and grade 3 is where you're looking at full thickness discontinuity of the involved endometrium over 1 centimeter in size. So this is how we're going to assess the endometrial impairment. So these are the results. Impairment immediately after HIFU, grade 0, there's no impairment, so 56.4%. Grade 1, there's 24.8% impairment. Grade 2, we have 13.7%, and grade 3, we have 5.1%. So if you now look at the follow-up, at 3 months follow-up for patients with endometrial grade 1 impairment, 15 normalized, 4 has no change, and 2 aggravated. And at 12-month follow-up, of the 2 patients that we have for follow-up, 1 normalized and 1 has no change. For grade 2 impairment, at 3 months follow-up, 6 were normalized, 3 improved to grade 1, and 3 has no change. So for 12-month follow-up, of the 6 impairments, 3 were follow-up, and then 2 normalized and 1 has no change. And for grade 3, at 3-month follow-up, 1 improved to grade 0, 1 improved to grade 1, and 2 had no change. However, at 12 months follow-up, the remaining 3 patients all had normalized endometrial enhancement. So in the image below, you're looking at the representation of the different patients across the different grades and how that improved at 3 months and 12 months follow-up time point. If you don't look at the impairment, cumulative in terms of percentages, at 3 months follow-up, we're looking at grade 0 increase from 56.4 to 76%, and then grade 1 at immediately after treatment is 24.8%, and then 3 months follow-up is at 11.3%. Grade 2 at 3 months follow-up is 5.6%, and then grade 3 is 4.2%. And at 12-month follow-up, grade 0 is now 87.5%, grade 1 is 6.3%, grade 2 is 6.3%, and there's no more grade 3 patients being followed up at this time point. And there's no findings of intrauterine adhesions were observed at 3 or 12 months follow-up. And then the risk factor for endometrial impairment were analyzed using univariable and multivariable analysis. For univariable analysis, the serum FSH level, degree of protrusion into the endometrial cavity, average acoustic powers are risk factors for endometrial impairment, whereas in the multivariable analysis, degree of protrusion into the endometrial cavity is the risk factor for endometrial impairment. So here is a case example of a 47-year-old woman with menorrhagia and dysmenorrhea before the HIFU treatment. You can see immediately after the treatment, there's a grade 3 impairment. You can see pointed by the arrows. The fibroid is about 2.3 centimeter in diameter. At 3-month follow-up, grade 3 impairment stays the same. Fibroid size reduced to 1.3 centimeter in diameter. And then at 12-month follow-up, the impairment resolved. Now we're at grade 0 with fibroid size about 3 millimeter. The conclusion from the studies were endometrium is mostly preserved or minimally impaired after HIFU ablation, and endometrial protruded submucosal fibroids are susceptible to more severe endometrial impairment, and the impairment may recover spontaneously at follow-up MRI examinations, as we have seen in this case example over here. So, what about the pregnancy outcome? There are different publications showing results of pregnancy outcome. A single center from Poland treated 276 patients where 20 patients conceived and 11 already gave birth at the time of the publication. In a review paper, as seen below over here, there were 100 pregnancies reported and HIFU has no impact on miscarriage, at least published by this review. And then let's take a look at what is the pregnancy outcome comparing HIFU to myomectomy to UAE. In this meta-analysis, which included 54 studies, 12,367 patients, where HIFU treated patients were 2,687, myomectomy patients were 6,646, and UAE was 3,034. So this 54 studies included 6 studies of RCT. Non-RCT were 38 studies, so 17 prospective and 31 retrospective study. What you can see over here, the pregnancy rate, HIFU is significantly higher than UAE, but lower than myomectomy. In terms of miscarriage rate, as seen on this table, there's no significant difference between HIFU and UAE and myomectomy. There are different clinical trials which are currently ongoing around the globe. So in Germany, there's a phase 3 study of MR-guided focused ultrasound surgery for treatment of fibroids comparing to myomectomy. In the Netherlands, there's a My Choice trial. It's an RCT comparing MR HIFU to invasive treatments such as hysterectomy, myomectomy, or UAE. In Finland, there's treatment of benign uterine disorder using MR HIFU. In France, we have MR elastography parameters impact on MR HIFU efficacy in uterine fibroids. In China, there's a study establishment of a decision aid tool for asymptomatic small leiomyoma and analysis of influencing factors for clinical decision making using HIFU. There's a pregnancy outcome registry study trying to capture the clinical pregnancy outcome and fibroid treatments background data for any subject post-exablate treatment for their symptomatic fibroids. There are different challenges when treating patients with HIFU treatment. HIFU is still, to some extent, lengthy procedure if you have multiple fibroids or very large fibroids. Not all fibroids can be treated. Example, highly perfused fibroids are not suitable for HIFU. There's also challenges in clinical adoption. There's a lack of RCT data. They're also challenging to obtain as patients want to get HIFU. And there's a lack of reimbursement, and there's also the challenge of ownership of the patients. There's a lack of awareness of the technology, and there's also different competing alternative treatments as well. Despite all that, I hope I've shown you that HIFU for uterine fibroid is a very promising technology. It's non-invasive, meaning you can retreat your patient. It's uterus preserving, so there's a possibility for pregnancy, as you have seen in the slides that I've shown. It's very precise. There's a fast recovery. You can go back to work within a week. It's very effective, and it's also safe as well. Thank you very much for your attention. I hope you enjoyed the lecture.